important because RCTs are considered to be the golden standard for research, as Harrington and Lacage in their 2018 study report, but they also argue that this kind of trials are more expensive, offer less opportunities for follow-ups, and do not represent minorities properly. In addition, RCTs are very important because on the basis of their results, the American College of Cardiology, American Heart Association creates their guidelines for diseases. The second study I analyzed was written by Zhang et al. In 2013, and it analyzes 250 cardiovascular trials conducted between 1997 and 2010. The first problem that they encountered was the lack of reports about patients' race or ethnicity. This was considered a great problem because this does not allow the researchers to have a clear portrait of the situation. And they suggested making it mandatory. So the mean enrollment rate they found for white patients was around 88%. African Americans and Hispanics were highly underrepresented, and Asian Americans were the only group that was properly represented in relation to their presence in the United States of America population. And then I analyzed the 2019 study made by Ortega and al., and it proves the underrepresentation of minorities in Food and Drugs Administration trials, which is extremely important because this means that on minorities, new drugs are not tested as extensively as they are on white patients, and this yields also problematic consequences, as physicians are not sure of the effectiveness or, in general, of the effects that drugs will have on minority patients. I then shifted my attention to answering my second question. So, what causes underrepresentation? The first factor is the cost of minorities recruitment. As a matter of fact, minorities are considered more expensive to recruit, especially because they have less access to the specialty care institutes that are chosen as referral basis for studies. And so they're also more difficult to recruit. In addition, minorities perceive as an hindrance for their participation a predominantly white staff, which may not tailor their approach to different cultures and language, and this may hinder understanding and may produce uncertainty that then leads the minority to decide to not enroll. And then we have psychosocial factors like mistrust that is usually due to lack of knowledge and fear of unexpected outcomes that may interfere and conflict with treatments patients are already undergoing and rise their medical expenses. In addition, there's also fear of exploitation, which is mainly due to the history of abusive trials in which minorities have been enrolled in a course of history. And a great example is the Tuskegee syphilis study. And then racism is also a factor in this field, and it can be internalized or interpersonal. Internalized racism may hinder and create hardships in communication between patients and providers. On the other hand, interpersonal racism may lead to discriminatory acts and the worst outcomes for racialized patients. I then went on to answer my third question. So, are minorities more likely to be affected by CVD risk factors? And the answer to this question is yes, but only in part. I mean that African Americans and Hispanics are more likely to be affected from CVD risk factors in most cases. Asian Americans instead have a lower mean rate for CVD risk factors than whites. So for hypertension, African Americans have a 10 to 12% higher likelihood to suffer from the disease than white patients. According to David Luz et al., instead, among Hispanics, hypertension is as bad as among white people, and Asian Americans have a lower mean rate than whites, with a mean rate that amounts to 16.9%. Cigarette smoking is considered to be another CVD risk factor, but for this one specifically, the situation is different from the others because all the three groups that I analyzed have lower level than whites. Regarding this specific CVD risk factor, I would like to reflect on a specific aspect, that is that among Asian Americans, there were some subgroups, for example, Filipino Americans, who had a smoking level that was 4.5% higher than the mean level for Asian Americans. And this yields an important reflection, that is that among Asian Americans and Hispanics, it is very difficult to find mean rates because the people making up these groups come from very different parts of the world, despite being in the same continent, and may be affected by same illnesses at different levels. For hypercholesterolemia, limited data was found and nothing regarding Asian Americans. I can say that African Americans are more likely to have high cholesterol levels. And in the Jackson Heart Study, this is what the JHS stands for, 1 in 3 patients of age between 35 and 84 suffered from hypercholesterolemia. In the Hispanic community health study of Latinos, more than half of men suffered from hypercholesterolemia, and almost 37% of women did too. Diabetes mellitus type 2 is another risk factor for cardiovascular disease, and African Americans are 1.52 times more likely among men to be affected from diabetes, and among women, there is a higher likelihood of 2.14 times than among whites. Also, the mean rate for Hispanics is higher than the one among whites, and the only group that has a lower mean rate is Asian Americans, but they develop it at a younger age and BMI index. The last CVD risk factor I analyzed was obesity. African American women are the group with the highest likelihood to develop obesity, and 58% of them suffer from this disease, 38% of African American men, and African Americans are also the group with the highest severe obesity rate, which amounts to 12.1% and is twice as much as that of Hispanics and whites. Hispanics enrolled in the Hispanic community health study of Latinos are also very likely to suffer from obesity. 41% of women and 52.6% of men enrolled in this study suffered from obesity. The lowest rate is detected in Asian Americans. And I then would like to go on and analyze what can be a cause for such high levels of obesity, for example, and also others CVD risk factors among minorities. As said, Hispanics and African Americans are the group with the highest likelihood to develop obesity, and this is due to an unhealthy, in part also due to an unhealthy diet and unhealthy lifestyle. African Americans and Hispanics are also the groups with the highest likelihood to live in what are called food deserts. According to the US Department of Agriculture, food deserts are areas with poor access to food and low-income areas. Poor access to food means that there are very few supermarkets which sell fresh fruit and vegetables in the area. And also they are kind of obliged to opt for the convenience stores and the unhealthy and pre-prepared meals that are sold in those. Living in a food desert is also a synonym of having a low socioeconomic status, which also may have as a consequence not having health insurance. Health insurance, however, in the United States is extremely necessary because is the only, is the easiest way, is the most convenient way to access to care, drugs, treatments, and Among African Americans, there is a very high level of uninsured people, which amounts to 10% of them. And among Hispanics, the uninsured level reaches 18%. This data may also come from the fact that some people do not own as much as it's needed to have a private insurance, but also makes more money than that's needed to have public insurance. And then after collecting all this data and analyzing it, I asked myself what could be done to change the situation and implement minorities representation in trials. So the first thing is investing more money to provide facilitators like free meal, childcare, remuneration, and other things that may that may allow patients who do not enroll for financial problems and tight schedules to actually enroll and be tested. Of course, this would constitute an important cost, but this would be repaid by maybe changing someone's lives or saving lives that, and after developing knowledge that before was not available. And it's also true that disparities have also a cost for the healthcare insurance. And in 2015, this cost amounted to $1.25 trillion of dollars. So surely the investment that would be needed to implement the minorities recruitment would be less than this. And then it's important to choose referral basis on the basis of a thorough and careful evaluation of the targeted population that should also include minorities. And then employing a more diverse staff would probably enhance minorities enrollment because people would be more likely to enroll in studies in which the providers are researchers are of the same culture or ethnicity as them. This would probably lower lack of knowledge and also the uncertainty that may yield from this. And then it's important in general to implement transparency and maybe with easy to understand protocols and comprehensive and clear information for patients. In general, I think, however, that one of the most important things that should be done is creating new recruitment strategy. A possible way to do that is the use of social media as a recruitment strategy. However, this has to be further tested to ensure its effectiveness and cost effectiveness. Recruitment is already a very challenging and costly process, and delays that go from 1 to 6 months may cost from $600,000 to also to $8 million. And in general, it is difficult to find people who want to participate in trials because everyone, regardless of their ethnicity, are scared of enrolling. However, some studies used social media as a recruitment strategy, and the review made by Topolovic, Ranick, and Nasrayan in 2016, they stated that 40% of the studies they analyzed and used social media as a recruitment strategy found it a valid way to recruit patients. But on the other hand, there is no certainty about their cost effectiveness, as said before, and so despite the fact that social media are very used by minorities, as shown in the graph, and shown by a report made by Pew Research in 2021, social media have still to be tested to see if they can be applicable for in this field. I then want to highlight the fact that I only analyzed three minority groups, which are Asian Americans, African Americans, and Hispanics in my research. But those three are not the only groups that constitute the American population. According to the last census, also Native Hawaiians, Native Americans, and people identifying as part of two or more races are other groups that constitute the American population. However, there's an absolute lack of information about those groups, and this also highlights the importance that the importance of new studies that actually include also other groups. So my presentation is finished. I want to thank you all for the attention. I want to thank the Scientex conference for the opportunity. It really means so much to me. I'm not a doctor. I don't have any degree. I'm still in high school. And for me, it really means a lot to be here today. I'm 17. I conducted this research thanks to the Research Made Simple program, which I want to thank from the bottom of my heart, especially the figure of Atmi Mehta, the founder, which gives high school students the opportunity to do research in a field of their interest over the summer. And I want to thank Samiksha Prabhu and Aisha Zia for the teaching and guidance during the whole process of writing the research. Thank you.
Thank you so much for such a wonderful presentation.